cancer therapeutics-related cardiovascular toxicity, which is the emerging fields of the cancer and both cancer and cardiovascular fields. My name is Hidehiro Kaneko from Tokyo University, Japan. It's my great pleasure to chair this session with Dr. Suphot Srimahachota from Thailand. And so I also deeply thank Professor Lin for organizing such an important session. At first, please let me introduce cardio-oncology fields shortly. In recent 20 years, the explosion of anti-cancer therapy has significantly improved the survival of the cancer patients. Concomitant with the great advance, cardiologists started to notice the emergence of new onset heart failure, hypertension crisis, and even fulminant myocarditis in cancer treatment by initially anthracycline, the monoclonal antibody against heart receptor, VEGF inhibitor for angiotensin suppression, multiple tyrosine kinase inhibitors, and the latest immune checkpoint inhibitor for lung cancer, etc. So many anti-cancer pathways and so many unexpected cardiovascular toxicity with a common risk factor between cancer and cardiovascular disease urges more cardiologists to devote in the integrated care of cancer patients during their much improved survival. It's a brand new frontier for all cardiologists to learn and update our knowledge together with our hemato-oncology colleagues.
So thank you, Dr. Kaneko from Japan. I work as a co-chairman for this meeting today. And the first topic will presented by Professor Kaneko in the topic of the shared risk factor and mechanistic biomarker between cancer and cardiovascular disease, a video of innovation. Please, Dr. Kaneko.
Thank you. So today I would like to talk about the shared risk factor between cancer and cardiovascular disease. Particularly, I would like to talk about the new concept of oncohypertension. I have no COI regarding my presentation today. So as I told you, the oncocardiology is a very important field in not only Western countries, but also in Asian countries, including Japan. And in Japan, the Japanese Oncocardiology Society was launched several years ago. And the Japanese Oncocardiology Society published several textbooks to share the knowledge of the oncocardiology and holds the annual scientific congress. And this society is now leading this field in Japan. There are many issues regarding the oncocardiology, but I think that the shared risk factor is one of the important. Is okay. I think that shared risk factor is one of the most important topics in this field. Can you hear me? Okay.
Okay.
It's okay?
Yeah, it's okay.
So please let me explain the concept of shared risk factor. So several risk factors of cardiovascular disease such as obesity, diabetes mellitus, smoking, and physical inactivity is associated with not only higher risk of cardiovascular disease, but also specific cancers. However, most of the evidence on shared risk factor come from the epidemiological data in Western countries, European countries, United States. So at first, we need to validate the concept of shared risk factor using the Asian epidemiological data. First, I'm interested in the shared risk factor concept in colorectal cancer. As you know, colorectal cancer is a very common cancer site in worldwide, and a very common cancer site for the cause of the cancer death. In Japan, colorectal cancer is the third most frequent disease among men and second most frequent among women. And it's responsible for the third highest number of cancer deaths among men and first among women, according to the cancer statistics of the National Cancer Center in Japan. The various risk factors for colorectal cancer are common to cardiovascular disease, including obesity, diabetes mellitus, cigarette smoking, and alcohol consumption. So, at first, we examined the association of fasting plasma glucose with incident colorectal cancer. As my postdoctoral fellow, Dr. Ito, examines the association of the diabetes mellitus and colorectal cancer. As you can see in this slide, the risk of the colorectal cancer increased with the fasting plasma glucose. I think it should be noted that the risk of the colorectal cancer was higher even in the people with a pre-diabetes state. Next, our fellow, Dr. Jimba, studies the relationship between the metabolic syndrome and colorectal cancer among young adults. As shown in this slide, compared with individuals without metabolic syndrome, individuals with metabolic syndrome are at high risk for incidence of colorectal cancer. So I think that the metabolic syndrome is very important for the prevention of colorectal cancer, even in young adults. Currently, we are interested in the new concept, oncohypertension. Regarding oncohypertension, our collaborator, Dr. Kidoguchi, has published a very important review article in hypertension. So if you are interested in this field, please refer to this important publication. There are many issues in the field of the oncohypertension. For example, potential association between hypertension or antihypertensive medication, blood-lowering medication, and incident cancer. Optimal blood pressure control in cancer patients is very important as well. Moreover, sometimes anti-cancer therapy, for example, VEGF inhibitors, will increase the blood pressure dramatically. Today, we will talk about the relationship of the hypertension with incident-specific cancer. At first, we examine the relationship between hypertension and the risk of developing colorectal cancer. As you can see in this slide, the incidence of subsequent incidence of colorectal cancer increased with increasing blood pressure. The result of the multiple Cox regression analysis demonstrated that compared with normal blood pressure, individuals having stage 2 hypertension was associated with a greater risk of developing colorectal cancer. This slide shows the result of subgroup analysis by sex. In women, as you can see in slides, blood pressure category, systolic blood pressure, and diastolic blood pressure were not associated with incident colorectal cancer in multiple Cox regression model. On the other hand, blood pressure category, systolic blood pressure, and diastolic blood pressure were all associated with higher risk of developing colorectal cancer. I think it is very important. Not only stage 2 hypertension, but stage 1 hypertension was associated with the higher risk of the future colorectal cancer events. Next, we examine the association between the blood pressure with incident other cancer types. In this study, we analyzed more than 1 million individuals without a history of these various cancers. In this cohort, the average blood pressure, systolic blood pressure was 117, and diastolic blood pressure was 72 on average. Average age is 45, and the 56% were men. This slide summarizes our main result. In multivariate Cox regression analysis shows that the systolic blood pressure was a higher incidence of thyroid, esophageal, colorectal, liver, and kidney cancers. On the other hand, higher systolic blood pressure was associated with a decreased risk of developing stomach cancer. I think this result is very important, but the underlying mechanism is still unknown. This slide shows the result of the district cubic spline. Similar to the result of the Cox regression analysis, increasing systolic blood pressure was associated with increasing risk of thyroid cancer, esophageal cancer, colorectal cancer, liver cancer, and kidney cancer. On the other hand, blood pressure was associated with a decreased incidence of stomach cancer. Our collaborator in Korean validated our result using the Korean nationwide epidemiology data. As you can see in this slide, the result using the Korean epidemiology data was similar to our data in Japan. Systolic blood pressure was associated with the higher risk of thyroid, esophageal, colorectal, liver, and kidney cancers. On the other hand, higher systolic blood pressure was related to the decreased incidence of stomach cancer. So this is a summary of our result. In the Japanese nationwide analysis, population-based database, including adults not taking antibiotic medication, higher systolic blood pressure was associated with a higher risk of incident thyroid, esophageal, colorectal, liver, and kidney cancer events, even after adjustment for multiple potential confounders. Our results were confirmed by the studies using the Korean nationwide epidemiological data. After I talk about the limitation and the future perspectives of our studies and this field. Although we performed the multivariable Cox regression analysis, we could not eliminate the possibility of unmeasured confounders and residual bias. In this study, with the data on blood pressure at the health checkup, but the data on blood pressure measurement at a single occasion, including health checkup, might not fully reflect on individual's blood pressure phenotype. Moreover, we use the epidemiological data, including administrative claims data. So, recording diagnosis of administrative claims data are generally considered less well validated. So there remains uncertainty regarding the accuracy of the cancer diagnosis. Unfortunately, the mean follow-up period of our database is only 3 years. I think it is too short for the study examining the epidemiological data of the cancer patients. As I told you before, underlying pathological mechanisms of our result still remain unknown. we need the future studies to uncover the underlying pathological mechanism of our result. Moreover, whether blood pressure lowering therapy, for example, using the blood pressure lowering medication, could reduce the risk of specific cancers such as colorectal cancer, kidney cancers, remains unknown. Conclusion: shared risk factor is an important topic in the field of oncology, even in Asian countries. A nationwide epidemiological database in Japan confirms a relationship between the metabolic disorders and the incident colorectal cancers. Optimizing metabolic factors would be essential for the prevention of both cardiovascular disease and cancers. Oncohypertension would be a novel concept of this field. We found that higher blood pressure was related to higher risk of developing thyroid, esophageal, colorectal, liver, and kidney cancers. So measuring blood pressure would be helpful for risk stratification of these cancers in general population. Uncovering the pathological mechanism underlying our result may help identify novel therapeutic targets for not only hypertension, but also cancers. Thank you for attention.
Thank you, Dr. Kaneko, for the interesting talk. May I ask some questions, Dr. Kaneko?
Sure.
Do you think that the high blood pressure or the treatment of the blood pressure correlation with the cancer? You mean, I mean that the treatment or the blood pressure itself?
I'm sorry, the internet connection is a little bit, please, could you please repeat your question?
Pardon?
Could you please repeat your question?
Okay.
Because our internet connection is
okay.
bad, sorry.
My question is, do you think that the high blood pressure or the treatment of the hypertension correlation with the cancer?
Yes, I think it is very important topic, but in our studies, we excluded individuals taking the antihypertensive medication, so that we could not conclude whether blood pressure lowering treatment or antihypertensive medication would be associated with the cancer risk. So that I think it is very also important field that and now we are accumulating the data regarding this topic.
And which patient do you recommend for the screening for the cancer in hypertension patients?
Yes,
or you screen all the hypertensions and which cancer you screening? Yeah.
Yes, I think it is also a very important topic. But as you see in my slides, the association between hypertension and the risk of the cancers, for example, colorectal cancer, was not so strong. So that's this relationship is much weaker than the relationship between the hypertension and cardiovascular disease. So that's at this time, we cannot recommend the cancer screenings based on the blood pressure values only. But as I showed in my slide, as other metabolic risk factors, so metabolic syndrome and the diabetes were also associated with increasing risk of the colorectal cancers. So that if the people having not only hypertension but also other metabolic risk factors, we would like to recommend them for the cancer screening, particularly colorectal cancer screening.
Yeah. So I think we can do the research in future for to make the who is a risk for the cancer.
Yeah.
This is an interesting topic. Yeah. So I'm not sure that is any question from the audience.
Maybe Dr. Hua has question or no?
Okay. Yeah.
Thank you so much, Professor Kaneko. I thought it was very interesting, your talk. I was curious when you mentioned about the VEGF inhibitors, such as tyrosine kinase inhibitors, and they can cause, hypertension as a side effect. And there were some studies that noted this association that if the patient does develop hypertension with, VEGF inhibitors such as tyrosine kinase inhibitors, they tended to actually respond better in terms of their cancer therapy to the VEGF inhibitors. I wondered if you had included, considered these in your models, if you could perhaps, postulate with regards to the relation, because it seems here that the development of hypertension seems to be actually a good thing for the cancer patient.
Yes, unfortunately, we did not have any data that's answering your question. As I told you, that in these studies, we exclude the patients taking the antihypertensive medication and the patients on treatment with chemotherapy, including the VEGF inhibitor. But we are now analyzing the data, including the cancer patients on chemotherapy, including the VEGF inhibitor. So I hope we can publish the latest data in the future. But unfortunately, so far we have no data regarding the question. Sorry.
Thank you.
Is any question? Okay, Dr. Chan.
Yeah, okay, that's Chang from Taiwan, and really enjoy your talk. It's very interesting topic. And actually, my question is, things that we know that certain kind of patient, like a patient with colon cancer or renal cell carcinoma, or they receive like a VEGF inhibitor or tyrosine inhibitors, they will have a high risk to have hypertension. Would you recommend any kind of protocols this kind of patient can follow? They have to regularly check their blood pressures, any kind of screening or any kind of method that we can early detect the hypertension in this patient. Thank you.
Yes, I think your point is very clinically important as well. But so far, as far as I know, that there are no large-scale data, including the blood pressure control in cancer patients. Now we are analyzing some data, including the cancer patients, and we examine the association of the blood pressure control with cardiovascular outcome in cancer patients, particularly cancer patients on the treatment using the chemotherapy. This is not unpublished data, so that we can open the concrete data, but the higher blood pressure was associated with dramatically increasing the cardiovascular outcome, cardiovascular events, particularly heart failure events in cancer patients regarding of the status of the active cancer treatment. So I think that the blood pressure control is, particularly strict blood pressure control can be generally recommended for cancer patients. But as you know, that many cancer patients has various status. So some patients are very weak, or some patients will need a complex chemotherapy, or so that we need the detailed protocol, including the blood pressure control regimen or guideline for the blood pressure control in cancer patients. But I think that we need time.
Thank you.
Any more questions from the audience?
if there's time, can I just ask one more quick question of Professor Kaneko? Yeah, I was just really interested with regards to the signal both in the Japanese and the Korean database of stomach cancers and having that inverse relation with blood pressure. I haven't actually read your paper, but I wondered if your group had postulated with regards to mechanisms for this. Is this really just a spurious association? And if so, then why have we seen it in sort of two different cohorts across two countries? Just wondering if we could just have some postulations with regards to the mechanisms of this.
Yes, at first, our hypothesis was higher blood pressure was associated with higher risk of stomach cancer. So that's at first I'm very surprised at this data, but our Korean collaborator confirms the association between the blood pressure with the decreased incidence of stomach cancer. So that's I have no idea regarding the mechanisms of this association. Do you have any ideas? But I think it's very important, but unfortunately, I have no idea.
I mean, I suppose if there were any signals with regards to blood pressure medications that the patients might have been on, you know, given that perhaps one postulation could be we have to look into the literature, but the type of medications having like a direct effect on the stomach lining itself, and at the same time having the association of bringing down one's blood pressure. That could be one postulation, but I thought that was a very interesting signal and definitely something to look into further, especially since it's been reproduced in a separate cohort. But thank you very much.
Thank you. Okay.
Okay, I think.
So may I move to the next speaker?
Yeah. Maybe you can introduce. Yeah.
Okay. So the second speaker is Dr. Chong Jun Hua from Singapore. The presentation, the title of her presentation is Cardiotoxicity associated with the anthracycline and tumor therapy, incidence, monitoring, and the dexrazoxane rescue. Dr. Hua, please. Could you please start the presentation?
Sure, I'll share my slides. Sorry, just having trouble bringing it up. It was fine before. Just give me a short second. Can you see my slides?
Yeah. Okay.
Great. Thank you.
Wow.
Thank you. So hello, everyone. Thank you so much for the opportunity to speak this afternoon. My name is Jun Hua. I'm a consultant cardiologist at the National Heart Center in Singapore. I was allocated this clinical topic, which I think is very apt following the amazing research that has been just presented by Professor Kaneko. I will be presenting on cardiotoxicity associated with anthracyclines, the incidence, monitoring, and dexrazoxane rescue. In addition to that, in the 20 minutes, I'll also be covering on the mechanism, diagnosis and definition, prevention, and management of anthracycline cardiomyopathy. I think it's a very clinically relevant topic to be presenting on. So I'm very happy to be presenting on it today. Anthracycline cardiomyopathy represents, you know, the main sort of cardiomyopathy that we see in cardio-oncology. Anthracyclines are cytostatic antibiotics first used in 1960s. The anthracyclines represent the base of treatment in many solid cancers and hematological malignancies, and are considered the principal culprit drugs behind chemotherapy-induced cardiotoxicity. The pathognomonic manifestation of anthracycline-induced cardiotoxicity is a hypokinetic cardiomyopathy that progressively leads to heart failure and was actually first described in 1967, shortly after they've been clinically used. Not only can anthracycline cardiomyopathy negatively affect the cardiovascular outcomes of patients, it can also limit the chemotherapeutic sort of potential of these strategies, of cancer strategies, as a dose-limiting toxicity. So the incidence of anthracycline cardiomyopathy really depends on the cumulative dose. The risk increases with the cumulative dose, 3 to 5% with 400 milligrams per meter square, and as high as 18 to 48% at 700 milligrams per meter square, the higher dose range of anthracycline. The risk also increases with concurrent use of trastuzumab, which interferes with myocyte survival pathways. Trastuzumab is a HER2 monoclonal antibody, which is often used in our breast cancer patients. There are also baseline risk factors that can affect anthracycline-induced cardiotoxicity risk, such as concurrent myocardial disease with existing heart failure, symptomatic or asymptomatic, previous coronary artery disease, moderate or severe valvular heart disease, hypertensive heart disease. Certain demographic risk factors, such as at the extremes of age, and also traditional cardiovascular risk factors of family history of premature cardiovascular disease, hypertension, diabetes, and hypercholesterolemia. And of course, previous cardiotoxic cancer treatment, like anthracycline use and prior radiotherapy to the chest or the mediastinum, and lifestyle risk factors, such as smoking, high alcohol intake, obesity, and sedentary habit, really in line with what has just been presented with regards to, hypertension and its association, and a metabolic syndrome and cardiometabolic risk factors. The mechanisms of anthracycline cardiotoxicity actually still remain unclear. One potential mechanism is the generation of reactive oxygen species, changes in iron metabolism, and CAP2B signaling. Topoisomerase 2B is actually a critical mediator of anthracycline cardiotoxic effect. In normal times, in normal conditions, it helps to uncoil DNA filaments during DNA replication, transcription, or recombination. The anthracycline inhibits topoisomerase 2B, and this in turn causes mitochondrial dysfunction and leads to activation of cell death pathways and reactive oxygen species deposition. The cardiomyocyte has always been considered the main cellular target of anthracycline toxic effect in the heart, as their destruction results in progressive development of cardiac dysfunction. More recently, however, other cell types such as cardiac progenitor cells, cardiac fibroblasts, and endothelial cells have been identified as potential additional targets. So far, the principal mechanisms with potential differential impact and grade of involvement in different cell types are oxidative stress, DNA damage, senescence, and cell death. As those who are familiar with readings in the field would know, there are different slightly modified diagnoses and definitions of anthracycline cardiomyopathy. The definition we'll use in today's talk would be the one that I think it's most commonly reported by Planner et al. And published in the European Heart Journal of Cardiovascular Imaging in 2014, which defines anthracycline cardiomyopathy as a drop of LVEF in absolute terms of greater than 10 points with a final value of less than 53%. There's a caveat to this. In patients with cardiac low risk, such as without risk factors or no cardiovascular history and receiving low dose of anthracycline, so a cumulative dose of 240 milligrams per meter square or less, cardiac monitoring is in fact not recommended as yet by the American Society of Clinical Oncology guidelines. And if you look internationally, international cardiological guidelines recommend the monitoring of cardiac function by serial left ventricular ejection fraction measurements, but they do not provide sort of a very prescriptive indication on timing, frequency, modalities, and the long-term schedule of this. Of note, a recent study by Cardinale et al. Published in Circulation in 2015 evaluated 2,625 patients scheduled for anthracycline therapy, and they showed that close monitoring of ejection fraction after chemotherapy allowed nearly all cases of cardiotoxicity to be identified. In addition, early treatment with ACE inhibitors and beta blockers enabled normalization of cardiac function in most cases, but only 11% of patients who have renormalized LVEF had full recovery, i.e. the same LVEF value as before the start of anthracyclines, while the final LVEF value in 71% of these patients remained below baseline value. These findings thus confirm that this approach is limited in identifying reversible cardiotoxicity, probably because left ventricular compensation mechanisms have already been exhausted. Of great importance then is that the evidence of normal LVEF does not actually exclude the risk of future deterioration of cardiac function. Therein lies this recommendation. It has been proposed that we are actually quite proactive with regards to the amelioration of anthracycline, starting with primary prevention in cardiovascular risk factor control and the various strategies listed here. In the hours, days, or weeks after chemotherapy, we aggressively try to detect preclinical cardiotoxicity in a bid to prevent left ventricular dysfunction. If there is an increase, subclinical increase in troponin, consider ACE inhibitors. If there is a decrease in global longitudinal strain, which is a subclinical myocardial deformation parameter on echocardiography, carvedilol beta blocker could be considered. In the months after chemotherapy, if left ventricular dysfunction does indeed review itself through a decrease in LVEF, a combination of ACE inhibitor and beta blocker can be used. And indeed, if overt cardiotoxicity is to develop in years after the chemotherapy with associated heart failure symptoms, not only should patients be put on ACE inhibitor and beta blockers, prognostic heart failure therapy, diuretics will also be indicated to offload the fluid, extra fluid on the patient and to enable treatment of their symptoms. In terms of preclinical early detection, there are several pros and cons to using troponin. Troponin would enable the prediction of the development of future left ventricular dysfunction, as well as its severity, because studies have shown that the peak value of troponin is closely related to the extent of left ventricular ejection fraction reduction. It would enable the stratification of cardiac risk after anthracyclines and allow the tailoring of the schedule of post-chemotherapy monitoring of cardiac function. Obviously, in patients with abnormal troponin, you would monitor them more closely. It would help you to identify cardiotoxicity-prone patients in whom a cardioprotective therapy can be considered. And it would also help to exclude most patients who don't have that subclinical early troponin rise from prolonged cardiac surveillance. On the other hand, repeated assessments of troponins are indeed needed to detect positivity. There is still debate with regards to the ideal timing for troponin detection to be performed. We need to standardize the routine use of troponin in the clinical setting, and also the timing in which a single sampling of troponin could be obtained also needs to be taken into account. We want to try and reduce the burden and the cost for cancer patients who already have many other procedures and appointments to get to for their cancer management. With regards to strain and GLS, several papers have demonstrated the value of global longitudinal strain in detecting subclinical myocardial dysfunction with prognostic relevance in terms of overt LV dysfunction in cancer patients. In the recent ASE and EACVI consensus, they defined a relative decrease of GLS of greater than 15% from baseline as an indicator of subclinical left ventricular dysfunction. And they've also defined appropriate use criteria for multimodality imaging, including the use of strain. It must be taken into account, though, that strain is not always available with all laboratories. Here in Singapore, just to share some local experience, we do use global longitudinal strain routinely in our cancer patients. This needs to be done in a rigorous and disciplined fashion with specific sonographers and specific machines and specific expert readers reading the scans to try to optimize as best as possible accuracy, precision, and indeed reproducibility. In the field of primary prevention, there are several strategies to reduce the direct cardiotoxic effect of anthracyclines. Present oncologic guidelines recommend limiting the total cumulative dose of anthracyclines to 450 to 550 milligrams per meter square. However, this can also limit the effectiveness of anti-cancer treatment. Moreover, significant variability exists in terms of the susceptibility to anthracycline cardiotoxicity, suggesting that there may be a genetic variation that might modulate the risk. Epirubicin, idarubicin, and mitoxantrone are analogs of anthracyclines that are less cardiotoxic than conventional anthracyclines. Epirubicin cardiotoxicity occurs after higher doses of doxorubicin. However, to obtain the same clinical response, higher doses must in turn be given. In preclinical studies in animal models, idarubicin and mitoxantrone also showed a less cardiotoxic profile than doxorubicin. In the heart, liposomes cannot get out of the vascular space because capillaries have tight junctions. As the tendency to accumulate in the cardiac cells is limited, this may reduce the risk of cardiotoxicity when using liposomal anthracyclines. On the contrary, the liposomes reach a high concentration in the tumor site, leaving the circulatory system where tumor growth damages the capillaries itself, and can be considered as a more targeted anthracycline delivery method. In terms of pharmacologic prevention, I've listed lifestyle measures under this. There is a strong link, as we've heard, between cancer and cardiovascular risk factors, and hence we need to address smoking and sedentary habits, potentially leading to obesity in our patients, as well as high alcohol intake. Of note, a healthy diet has been associated with a protective effect in terms of cancer relapses and cardiovascular disease, while smoking has an ominously detrimental effect. Several pieces of evidence have also emerged on the protective role of exercise training and eventually cardiac rehab against cardiotoxicity. In terms of the use of dexrazoxane, the use of these cardioprotective drugs such as dexrazoxane to reduce the cardiotoxic effect of anthracycline is a potential alternative to anthracycline treatment modifications, dosage limitations, or interruptions. The hypothesis that iron chelators may reduce the cardiotoxicity induced by anthracyclines suggests that dexrazoxane may be clinically useful as a cardioprotective agent. Doxorubicin is a potent TOP2 inhibitor. In the clinical scenario, many studies demonstrated that dexrazoxane significantly reduces cardiotoxicity in adults and pediatric populations. Patients treated with dexrazoxane has a significantly lower incidence of heart failure than untreated patients. However, apart from patients with metastatic breast cancer treated with doses of doxorubicin of greater than 300 milligrams per square, and despite previous findings, dexrazoxane is not routinely used in clinical practice because of suspicion of interfering with the anti-tumor effects and the occurrence of secondary malignancies. In fact, in September 2011, the European Medicines Agency had placed several restrictions on dexrazoxane use in both children and adults with cancer. Several new trials, however, on the benefit-risk of dexrazoxane have been published since then. And so far, it has been demonstrated that dexrazoxane results in an effective cardioprotective effect when administered with anthracycline chemotherapy without a reduction in anti-tumor efficacy or survival, and can be recommended as a cardioprotective agent, particularly in children and adolescents for whom the development of anthracycline-induced cardiotoxicity could have a crucial prognostic impact. Here in Singapore, I can confirm that with regards to pediatric hematology-oncology cancers, dexrazoxane is frequently used as part of their protocol, but in adult cancers, it's mainly restricted to metastatic breast cancer at higher doses of anthracyclines. With regards to cardiovascular drugs, showing a prophylactic effect against anti-cancer therapy-induced left ventricular dysfunction in adult cancer patients, we have already discussed with regards to the use of ACE inhibitor and beta blockers. Here is a table summarizing the various trials looking not only at ACE inhibitors and beta blockers, but also with aldosterone antagonists and statins and their cardioprotective effect in anthracycline cardiomyopathy. In conclusion, anthracycline-induced cardiotoxicity is still a significant problem that compromises the quality of life and overall survival of cancer patients. However, recent findings demonstrate that this form of cardiomyopathy is mostly reversible with early detection and prompt therapeutic introduction strategy being likely to be prioritized. It is likely that anthracycline-induced cardiotoxicity is a single and continuous phenomenon as opposed to the traditional early versus late classification from cellular to clinical stage, starting with myocardial cell injury, followed by progressive LVEF decline, and potentially overt heart failure. The current standard for monitoring cardiac function, such as periodic, like 3-monthly assessment of left ventricular ejection fraction, detects cardiotoxicity potentially at a late stage when significant impairment has already occurred. And this then precludes the chance of effectively preventing and treating its development. The use of troponins to identify patients with subclinical cardiotoxicity combined with early treatment with ACE inhibitor occurrence appears to be an effective method to prevent anthracycline-related left ventricular dysfunction and cardiac events. Finally, adoption of a multidisciplinary team approach may actively help in optimizing patient management. In this regard, seminars such as this to help encourage conversation between cardiologists and oncologists, and indeed, allied health staff and nursing staff and our surgical colleagues as well, will enable active collaboration for optimal clinical outcomes. Thank you.
Thank you, Dr. Hua. Is there any question from the audience? Okay. Dr. Kaneko.
Dr. Hua, thank you very much for wonderful presentation. I'm very moved with your presentation. I'm not familiar with this field, but I'm interested in the precision medicine. I think it's very important to predicts cardiotoxicity of cancer patients. So is it possible to predict cardiovascular toxicity using the genetic information or genetic data? Do you have any data?
So, in my readings in preparation for this talk, there are sort of preclinical studies looking at agents such as microRNAs. I believe that there are also, various papers that have linked sort of registry data and genomic data together. And, they've shown that there are certain microRNAs that are more associated with the development of anthracycline cardiomyopathy. So, and also titin cardiomyopathy as well. I suppose, this is all very interesting data. Ultimately, we need to know how much the cost would be as well to introduce this clinically, how much would it cost to actually profile our patients in terms of their genetics or indeed epigenetics. But if we are able to successfully identify patients that are predisposed to anthracyclines, even before giving anthracyclines, such that we would put them under very heavy surveillance through the use of epigenetics, microRNA, or indeed, as you suggested, genetic data, I think that would be very useful for these particular patients, especially the ones, the pediatric patients and the ones receiving very high dose of anthracyclines.
Thank you very much.
Thank you.
Dr. Shan, please.
Yeah, very nice presentation. Thank you so much. I think that this issue is very important and have been studied for a while, but actually still have lots of problems that is unresolved. Like you mentioned that about the protocol, like how to screen these patients. And usually the guideline will recommend that every 3 cycles of the treatment of anthracycline, and we can do echocardiography. Actually, there's a large number of patients. So I think it is possible that we'll be modifying the protocols or any kind of possible risk factors. We can recognize these patients in the early stage so that we can do the protocol. And the other question is that because we don't have much experience about the dexrazoxane, so what kind of patient would you recommend to give these prescriptions before the anthracycline therapy? Thank you so much.
Yeah, thank you so much for those questions. I think that those are very pertinent discussions to be had, particularly within a cardio-oncology setting. With regards to, I think with regards to your first question, so just to share in terms of the Singaporean experience, we would just have a blanket rule that we would offer, echoes at least 3 monthly with patients that are on anthracyclines and indeed even HER2 agents. Not so much perhaps the newer HER2 agents like pertuzumab that that don't tend to be associated as much with cardiomyopathy, but certainly with the more traditional HER2 agents like trastuzumab that are used very commonly and concurrently with anthracyclines, having that two-hit hypothesis. Because, you know, the thinking is that anthracyclines basically induce this cellular repair within the myocyte, but the HER2 then also blocks that last strand of, you know, survival for the cell, and that then, you know, potentiates the cardiotoxic effect of anthracyclines. So we actually have a blanket rule that we offer 3 monthly echoes for these patients. We also liaise very closely with our oncology colleagues, you know, on the phone. It's just, you know, basically try and be very contactable in a multidisciplinary setting, in a cardio-oncology kind of workflow setting. If they had any concern in their oncology follow-up that the patients was developing symptoms, we would offer them an echocardiography, even, you know, sort of on the spot with global longitudinal strain, with, you know, the workflow being able to as best as we can accommodate, you know, last minute requests with regards to this. It's not always easy, but we just try and do what's realistic. With regards to the baseline risk factors, you know, as per the table that was, you know, published by Cardinali et al. In her multiple publications in this topic, you know, definitely with the baseline risk factors, the traditional cardiovascular risk factors, those tend to potentiate the risk of anthracycline cardiomyopathies. Also in patients who are unlucky enough to have had, you know, pediatric cancer and mantle, you know, radiotherapy, for instance, for lymphoma, and then subsequently develop adult, you know, cancer like breast cancer, those patients who have had previous chemotherapy and mediastinal radiotherapy as well, those would be at higher risk, and we would still keep to our 3 monthly. We would closely monitor the strain, and we'll have a low threshold to organize an echocardiography or indeed do subclinical biomarkers like troponins for these patients.
So do you,
with regards to,
so
sorry,
do you, oh, sorry, okay. Go ahead.
Okay, I was just going to quickly answer with regards to the dexrazoxane. You know, I've asked around with regards to my oncology colleagues and also with my colleagues in, you know, Australia. It's not actually used very commonly. I suspect that it's due to back in 2011 with that legacy effect. People are a little bit scared. They don't want to give this drug to protect the patient's heart, and then only for it to have, like, you know, inferior anti-tumor efficacy in the end and have the patient have their cancer progress. Even though the EMA appears to have sort of lifted some of that restriction. In Singapore, we use it mainly in the pediatric populations. When speaking with my pediatric oncology, hematology colleagues, they mainly use dexrazoxane as part of their protocol in pediatric patients that are going to receive high dose of anthracyclines. And in the adults, we would keep to the guidelines here in Singapore. So with metastatic breast cancer that are receiving, I think, greater than 300 milligrams per meter square of the anthracyclines.
Do you recommend to take troponin or BNP before starting the chemotherapy or the case?
Yeah, I mean, if we were involved from the get-go, we would usually do that. I don't think through the oncology side they would do that unless there were symptoms of heart failure or you know, or chest discomfort. Indeed, I think that it's very useful to actually have a baseline values because some patients get chronically elevated levels.
Okay, thank you, Dr. Chirapat, please.
So thank you for the great talk. As we follow the guidelines, and we recently found a lot of patients, not a lot, but some patients who had elevated troponin and biomarkers like BNP with completely asymptomatic and without the drop of the strain. So would you recommend treating these patients, for example, ACE inhibitors, beta blockers, or would you recommend to follow or do additional tests? Thank you.
Thank you. I mean, I think that that's the million-dollar question. I think the cardio-oncologist, particularly Cardinale's group with her studies on, you know, like the preclinical toxicity of anthracyclines would certainly purport to, you know, implement ACE inhibitors. And there are some, you know, smaller studies that seem to suggest a benefit. We must bear in mind, though, that these cardiovascular drugs come with them, you know, side effects as well. You know, just hyperkalemia with ACE inhibitors, some small risk of anaphylaxis, hypotension, and renal dysfunction. So we'll have to bear that in mind when starting. What I would do if I had a patient with a mild troponin rise in the absence of any symptoms or ECG changes, I would actually try to follow them up, really quite closely, maybe even on a weekly basis, just to perhaps track their troponin, such that, I kind of find a compromise between over medicating and also under surveilling the patient. If the patients had any clinical symptoms whatsoever of even like mild pedal edema, breathlessness, and even a slight drop in strain, and also had other reasons, for instance hypertension, to be started on an ACE inhibitor, which often is the case because it seems to be very, very common in our cancer patients, as we've seen with our previous talk, and certainly in my clinical practice as well. I always find a reason, to start an ACE inhibitor, obviously to treat their hypertension, knowing at the back of my mind that it would probably execute sort of like a cardioprotective effect whilst they're undergoing their cancer therapy. So that's what I would do.
Thank you.
Thank you.
May I ask the last question for you? If the patients have low ejection fraction before starting an anthracycline, how do you recommend for these patients?
Yeah, I think I always tell myself my most important job is not to get in the way of their primary cancer therapy. As the cardiologist, we really are there to help them along with their cancer treatment and in a way that they don't have any long-term cardiac side effects after surviving their cancers. I guess it really depends on how low. If it was, sort of on the borderline for a woman, 52% with no symptoms, we could always sort of proceed with caution with very heavy monitoring. I think at the end of the day, though, we've often included, always actually included the patients in these discussions to explain to them the risk of getting anthracycline cardiotoxicity is increased when you already have predisposing factors such as low LVEF to start with, when the cumulative dose increases, and what we'll do, as a team is to heavily monitor and monitor very closely, potentially starting, a cardioprotective agent first up, like an ACE inhibitor or a low dose of beta blocker. Patients often, in my experience at least, once you communicate these risks to them and let them know that you're doing everything you can to watch them and look after their hearts as best as you can through their cancer therapy, they seem to be quite receptive of these methods. But I take your point that there is no kind of hard and fast rule. Ultimately, we just have to communicate between the specialties and with the patients themselves.
Okay, thank you very much. Very interesting topic. Yeah. Okay. So I think we will move on to the third speaker. Yeah. May I introduce Dr. Yun-Gyoo Lee from Korea. He is associate professor in hematology, medical oncology from Chong Jun Hua University Hospital, Korea. Please. He will talk about the cardiotoxicity and vascular toxicity associated with VEGF signaling pathway inhibitors, Bevacizumab versus a novel tyrosine kinase inhibitor. Dr. Lee, please.
Thank you, Chairman. Can you hear me? So can you see my slide?
Yeah. Okay.
Thank you for inviting me to this wonderful webinar. I guess I'm the only one medical oncologist who are attending in this webinar, so I'm very nervous. Yeah, because I do not have a lot of information for cardiology. Okay, my topic is some cardiotoxicity and vascular toxicity associated with VEGF signaling pathway inhibitors. So I'm a medical oncologist. And I have nothing to disclosure. So today I will start with some VEGF signaling pathways, and then I will talk about some VEGF signaling in tumors, and then can move to the therapeutic approaches for some VEGF inhibition, which includes some monoclonal antibodies and therapeutics inhibitors. And then finally, I will talk about some cardiovascular toxicities during anti-VEGF treatments. So this is the VEGF signal pathways. So as you can see, the VEGF-A, the master regulator of angiogenesis, usually this ligand can bind to VEGF receptor 2. This is a key receptor molecules for some VEGF signal pathways. So binding this VEGF-A and VEGF receptor 2, they can provide some signal through the LAF, and MARC and ERK signal pathways. And they can also stimulate the migration and proliferation of endothelial cells. And they can also increase the vascular permeability by increasing the endothelial unnatural cell synthase. And they can also trigger vascular relaxations. But if we look into deeper of VEGF signal pathways, the signaling seems to be more complex. So besides VEGF-A, there are another some molecules such as VEGF-B and placenta growth factor named as PIGF. Then VEGF-B and PIGF usually can bind some VEGF receptor 1, and VEGF-A can bind VEGF receptor 1 as well as VEGF receptor 2. So as I mentioned in the previous slide, the VEGF receptor 2 is the major signaling receptor in VEGF signaling pathways. And there are some ligands, VEGF-C and D, which can bind to VEGF receptor 3. And VEGF receptor 3 is known for some key regulator of some sympangiogenesis. And altogether, the signal usually can promote some vasculogenesis and angiogenesis at all. In tumors, interestingly, when the tumor grows, the hypoxia was happened, especially in the peripheral area of the tumor and the outside of the tumor. The cancer can encounter the hypoxia. And usually hypoxia can induce the HIF-1 alpha. So HIF-1 alpha usually can promote the expression of some VEGF. So the T-cell hypoxia in cancer is one of the critical driving force for some increased expression of a VEGF in tumors. So the increased expression of a VEGF, they can bind some VEGF receptor 2, and they can activate the tyrosine kinase domain inside the cell membrane. They can transduce the signal to the nucleus. And in tumor and in active solid cancers, this kind of VEGF-induced angiogenesis is very, very highly activated. So in normal tissue, some anti-angiogenic signals and pro-angiogenic signals were well balanced, but in tumors, the pro-angiogenic signals would predominate. So and this kind of some VEGF-induced some increased activation of VEGF signaling, they can induce some chronic vascular hyperpermeability, and they can induce some growth of some structurally abnormal and immature vessels. So as you can see at the figure B. In this slide, I would like to talk about some cancer stem cells, because autocrine VEGF signaling, so which means the cancer stem cell make some VEGF, and VEGF can return to their signal to stem cell by itself. So in cancer stem cells, this kind of autocrine VEGF signaling is very important and necessary to maintain the stem cell pool and sustain cell renewal. So interestingly, this kind of VEGF and VEGF receptors were very, very highly expressed in various kinds of solid cancers. As you can see in this table, the bladder and brain and breast and colon and gastric, and I think every kind of solid tumors can express this kind of some VEGF and VEGF receptors in very highly level. So therefore, we can think that targeting for VEGF signaling is a promising therapeutic strategy in cancer treatment. So the targeted cancer therapy, when we usually call this therapy as the other words, molecular targeted therapy or some biologic therapy, has a deep, very diverse group of agents. So the targeted therapy usually can block the distinct pathway essential for some tumor development, and they finally interfere the growth and progression of myeloid cells. And in general, the targeted therapy consists of two kinds of groups. The first one is monoclonal antibodies. Usually, as you can see in the right figure, the monoclonal antibodies can target some receptor, presenting in the surface of the cell membrane. So the Bevacizumab is included in monoclonal antibodies. And the another class of the targeted therapy is tyrosine kinase inhibitors. We usually call it TKIs. So sunitinib and sorafenib, many kinds of TKIs end with the NIB, usually can be included in tyrosine kinase inhibitors. The TKIs has very small molecular weight, so they can pass through the cell membrane, and they can act in the region of tyrosine kinase domains presenting just inside the cell membrane. So the TKIs can prevent some receptor phosphorylation by blocking some active binding domains in tyrosine kinase domains. So they can finally block the signal transduction. I think there are some misconceptions for this kind of targeted cancer therapies. Many people and many specialists think that targeted therapy has very little toxicities, but I would say there's no, because they have some very on-target and off-target toxicities, and the cardiovascular toxicity is one of them, because the targeted therapy can share some receptors between malignant and healthy cells, and they can touch every kind of some targets. This table shows two kinds of some VEGF and VEGF receptor signaling inhibition. So the upper table can show the monoclonal antibodies to target VEGF. Some Bevacizumab and aflibercept usually can target some VEGF, and usually some metastatic colorectal cancer and renal cell carcinoma. So we can use the Bevacizumab and aflibercept. But in patients with some non-small cell lung cancer and glioblastoma, you can treat the patient with Bevacizumab. And the lower table can show the tyrosine kinase inhibitors. So there are so many kinds of some TKIs, some such as axitinib and cabozantinib and pazopanib and regorafenib and sorafenib and sunitinib and bendatinib. And I think in the near future we will have more some kind of some TKIs to target the VEGF. So as you can see, in case of some TKIs, they usually target some VEGF receptor 2. As I mentioned, the VEGF receptor 2 is a key receptors in VEGF signaling. So, and most of them can be used to treat some renal cell carcinoma and metastatic colorectal cancer, and some for sorafenib, they can use some hepatocellular carcinoma and medullary thyroid cancer. In this table shows the anti-VEGF monoclonal antibodies, and there's some common and serious adverse events. Bevacizumab can target some VEGF, and the common adverse events usually have a lot of some non-specific symptoms, pain, nausea, vomiting, and we need to focus on the hypertension. And for some serious adverse events, serious means some more than grade 3 adverse events. They also include some hypertension and thromboembolic events and cardiovascular events. this table shows the anti-VEGF TKIs and their common and serious adverse events. So common adverse events, most of them, all of them include some hypertension as their common adverse events. And for some serious adverse event effects, the arterial and venous thromboembolism and heart failure and myocardial infarction also included in this serious adverse event. So as you noticed, for some anti-VEGF TKIs, they have some diverse cardiotoxicity, including some heart failure and myocardial infarction. So we needed to monitor the happen of this kind of some serious cardiovascular events. So when we look into the hypertension more detailedly, so hypertension can be observed more frequently with VEGF inhibitors. So all kinds of TKIs, and including some Bevacizumab, some monoclonal antibody, have some in patient who are receiving this drug can have some hypertension. This is an on-target toxicity, and the hypertension usually occurs within the first months of the treatment, and some patients usually the hypertension can occur some 1 or 2 days after the treatments start. And the overall incidence of hypertension is ranging from 20 or to 30, but the frequent incidence of hypertension can depend on the individual agent. So in patients with mild to moderate hypertension, I just usually observe the patient carefully. But in patients with severe hypertension, I lead to some dose modification of anti-VEGF, and I usually refer this patient to my cardiologist for some pharmacological intervention. So, and in the very rare cases, in patients already have some hypertension, if the patient receives some anti-VEGF TKIs or monoclonal antibodies, they can cause some posterior reversible encephalopathy syndrome, PRAS syndrome. It will vary some serious and rare some adverse events. So I think we all needed to think about this. And the hypertension during the various anti-VEGF TKIs, the degree of some increase of high blood pressure is depend on the specific some TKIs. So the sunitinib, ensorafenib, pazopanib, cabozantinib, exitinib, all of these TKIs can be treated for some renal cell carcinoma. Among them, exitinib can increase blood pressure the greatest. So as you can see in this slide. So if you consult the patient who has some hypertension during the anti-VEGF TKIs, you need to find which kind of TKIs the patient can have. So this anti-VEGF inhibition can also cause some other cardiovascular toxicities. So the second one is pulmonary arterial hypertension. So this is the kind of some off-target effect of the drug, and the frequencies are quite rare, from 0.5 to 1% for some dasatinib kind of some CML some treatment. And usually this kind of pulmonary arterial hypertension can be known for some dose dependent, and this can develop after some 1 year of maintenance period. And fortunately, if we discontinue the drug, the pulmonary arterial hypertension can be some reversible. And the other kind of some special toxicities is QTc prolongation. This can be regarded as an on-target and as well as off-target effects. So if the patient who have some QTc prolongation more than 500 milliseconds or some 60 milliseconds from the baseline, this can increase the risk of ventricular tachyarrhythmias. So we need to be very careful to use some VEGF TKIs in patients with underlying cardiac diseases. And the other some cardiotoxicity is some thromboembolic events. So Bevacizumab, some VEGF, anti-VEGF monoclonal antibodies, is related to the arterial thromboembolism. So the frequency is ranging from 2 to 3%. It is not common, but it's not so rare because the incidence of 2 or 3% is twice as high as in patient who treated with some conventional cytotoxic chemotherapy. So in patient with renal cell carcinoma and colorectal cancer, they are at a very, very high risk for arterial thromboembolism. And sunitinib and sorafenib also related the increased risk of arterial thromboembolic events compared with the control. So, so this kind of embolic events can happen more openly in patients who receiving some VEGF inhibitors. And unlike the arterial thromboembolism, the risk of venous thromboembolism is not so increased much. So from the one study, the relative risk for venous thromboembolism is not increased so highly. So we usually do not recommend to prophylactics especially for these patients. This is the real world some data conducted in Europe, and this is a population-based study. This study estimated the major adverse cardiovascular events in patients who receiving some anti-VEGF. The y-axis, the cumulative incidence of MACE, and the x-axis really represents the time from the treatment of months. So as you can see at the figure A, in patients who receiving pazopanib and sunitinib and sorafenib, the incidence of thromboembolic events increasing very linearly along the time. So compared to the thrombotic events, the rhythm disorder and heart failure and pulmonary embolism lead to some plateau just after 6 months of treatment. So the incidence of MACE is somewhat different. And finally, the cumulative incidence MACE of almost 10% after 1 year of this kind of some anti-VEGF TKIs. And as you see in this slide, in patient with the bevacizumab, the incidence of MACE is increasing linearly, but the cumulative incidence of MACE is slightly lower than in patient who receiving some VEGF TKIs. And interestingly, as you know, the trastuzumab is the very well-known monoclonal antibody to target some HER2. We all aware of that in patients who receiving trastuzumab are more likely to have some cardiovascular risk, but the cumulative incidence of MACE is quite lower than the other VEGF targeted agent. So I think we need to monitor more carefully, especially in patients who receiving the VEGF inhibitors. So as you can see in my presentation, the VEGF inhibitor has some dual effects, some beneficial effects of anti-cancer benefit and the harmful effects of vascular toxicities. So I think we need to do some ideal management of the patient to balance angiogenic and cardiovascular toxicities. So in summary, the VEGF inhibitors usually has improved the clinical outcomes in cancer patients. And all VEGF inhibitors can elevate the blood pressure. This is the on-target effect and the class effect, so we can avoid some hypertension and we can escape from the risk of increased blood pressure. And anti-VEGF also induce pulmonary arterial hypertension and arrhythmia and thromboembolic events. So the balance management between anti-angiogenic and cardiovascular toxicity is important. And to do that, the close collaboration between medical oncologists and cardiologists are warranted. Thank you for your attention.
Thank you, Professor Lee. Is there any question? Okay, Dr. Hua, please.
Thank you. I might ask this. I've always had this burning question then, as a medical oncologist, if you started someone on a VEGF inhibitor or TKI and they had a quite a marked hypertensive response, is that something that you're happy to see in terms of the anti-tumor efficacy? Is that a signal to you that the patient is responding in terms of their cancer? Because you mentioned about hypertension being an on-target effect. I was just wondering if you could just explain a little bit more on that.
Thank you for your some good question. And the presence of hypertension does not translate into the anti-tumor effect. But I think in patients who receive some anti-VEGF TKIs or Bevacizumab, most of them can experience some increase of blood pressure. I'm not sure that the hypertension can represent of the anti-tumor activities of the TKIs. So, but in other kinds of some TKIs, such as some anti-EGFR, some the increased events of some anti-EGFR toxicities can be related to the improved response of the tumor. So I think in case of the VEGF TKIs, so I'm not sure. Yeah.
Thank you.
Is any more question? Professor Lee, may I ask you one question? Do you think that the VEGF inhibitor or TKI, do we need to monitor or surveillance as intensive as anthracycline-based therapy? Is the same?
To be honest, when we prescribe some anti-VEGF TKI to my patient, some renal cell carcinoma, they have very limited some survival, about 2 or 3 years. So I usually check the blood pressure when the patient visits my clinic, but I usually do not think the slight increase of blood pressure is a kind of serious problem. So, but I'm not sure that whether we can monitor those patients carefully just to monitor the blood pressure. So we need to more discussion between some oncologists and cardiologists and the risk of some MACE in this special population. Yeah.
So no need to do echocardiogram because it's burden for us.
I usually check the echo at the very early stage of the cancer treatment, and if the patient has some cardiovascular symptoms, we usually refer those patients to the cardiologist, because I do not usually order the follow-up echo order. I just to take my patient to my cardiologist colleagues to monitor any kind of some event for some cardiologic toxicities. So I'm not sure, because we do not have some very special protocol for this kind of some special population. So I'm not sure. Sorry for that.
Okay. Okay. Professor Kaneko, please.
Okay. So Dr. Lee, thank you very much for the wonderful presentation. As you may know, I'm interested in the blood pressure control in the cancer patients, particularly patients undergoing the VEGF inhibitor therapy. So do you have any recommendation for the specific blood pressure values for patients undergoing the VEGF therapy? So for example, 140 for systolic blood pressure or something.
There is very good question, and As I mentioned, I usually refer my patient to my colleague, my cardiologist, but most of my patients usually already have antihypertensive drug when they started the anti-cancer medication. So when they complain about increased some level of blood pressure, I usually recommend to dose of the antihypertensive drug, which they already have. And if I cannot control their blood pressure within their normal range of their blood pressure, actually refer my patient to my cardiologist to add another class of antihypertensive medication. So yeah, but the absolute value of hypertension to intervention, I'm not sure because I do not have some enough information regarding the target BP for my patient. I just follow my patient parallelly and in my clinic and the cardiologist clinic. So yeah, I just follow the strategy of my cardiologist. Yeah.
Okay. Thank you very much.
I think we have a running of the time. So we move to the next speaker. Please, Dr. Kaneko, to introduce.
Thank you. So the next speaker, fourth speaker in this session is Dr. Wai-Ting Chang from Taiwan. The title of her presentation is Cardiotoxicity associated with HER3 inhibitors for breast cancer, Trastuzumab versus novel dual tyrosine kinase inhibitors. Dr. Chang, could you please start the presentation?
Okay. Oops, sorry. Okay, thanks everyone. It's really nice that it's my pleasure to present this topic here, and especially to make me recall that it's actually it's 2018. Sorry, we hold the Congress of the APSCs in Taiwan, and it's the first time we have a cardio-oncology sections, and it's really nice that to have more and more people pay attention to about this issue, which is very important. And I just want to quickly raise the case. This is Miss Lin, and she is 45 years old. And I'm married with 2 kids. And she recently diagnosed with left breast cancer, and it's a stage 2A. And she has HER2 positive and ERPR negative, and the Ki-67, this is 30%, which is really high. And she didn't have any kind of cardiovascular risk factors and even family histories. And she completed the FEC therapies for 6 cycles. And then she under Trastuzumab and every 3 weeks. But this one thing that she come to my clinic because she has Sjögren's and edema for 2 weeks. And this is one thing very surprising, that is her blood pressure is very high since she didn't have any kind of history of hypertension. And this is the baseline echocardiography. You can see the drift function is about 65%. But after 6 months and we follow echocardiography, it dropped to only 50%. So today I want to raise some important issues. The first is about the CTRCD, which is a cancer therapy related to cardiovascular dysfunction. So actually, when we focus on cardio-oncology, we not only look at the heart value, actually have a lot of issues we have to focus on, like Dr. Lee just mentioned, like hypertension and also like thrombosis event. And today our focus is about Trastuzumab and the novel dual tyrosine kinase inhibitors in breast cancer. And the other issue is about how to do early diagnosis and also prompt management. And the other thing today I want to share our experience in Chinmay Medical Center in Taiwan. We have 6-year experience about their prospective screening programs in breast cancer patients. And like a CTRCD actually is a drop of left atrial fraction for more than 10% to a value below 50%. Actually, this is the idea for oncologists, not from cardiologists, because there is from the HERA2 study. And but that's one thing we have to pay more attention is that most of the patients, they don't have significant symptoms. They only have dropped myocardial functions. So maybe we can use like global trends, and which we mentioned previously, and the drop of strength maybe can early detect myocardial dysfunction. In the past, we have like type 1 and type 2 cardiotoxicities. Like type 1 is anthracycline-induced toxicity, and type 2 is more like monoclonal or like TKI-induced myocardial dysfunction. But today, actually, we have different kind of ways to have classifications. Like this is being raised by International Society of Cardio-Oncology, and now maybe we have think about the 5 different types of cardio-oncology. Like possibly the cancer per se can induce myocardial dysfunction, or like cancer therapy, or like the cardiac dysfunctions can contribute to the development of cancer. And also like the cardiovascular therapies maybe can also induce the happiness of the cancer. And the other thing is about the common risk factor. Like we mentioned about the metabolic syndromes, maybe can cause the development of cancer and also contribute to the development of cardiovascular dysfunction. So today, my focus is about like monoclonal antibodies or like a TKI. And so like the previous speakers mentioned that we have on-target effects. Like we use these kind of drugs to have specific pathways to control the growth of the cancer. But possibly we'll also have a bystander effect to the endothelial cells and also the cardiomyocyte to cause the dysfunction of our cardiovascular systems. So not only about the myocardial dysfunctions, cardio-oncology will also have to focus about the arrhythmias, like ischemia, or like thromboembolic, or like hypertension. So there's a lot of things to do. But who is at risk? So previous studies told us that maybe patients have very young age, like pediatric cancer patients, or like very old age, or they have combined anti-cancer therapies, or like radiotherapies, or they have myocardial dysfunction at the baseline. This kind of patient, maybe they will have high risk to have CTRCD. But unfortunately, still have a lot of patients, like our examples patients, and she didn't have any kind of cardiovascular risk factors or this kind of phenomenon, but she still developed the myocardial dysfunction after treatment. So I think it's very important to find and early detect about their myocardial dysfunction and also correct risk factors of these patients. And the other thing is about which kind of cancer should we focus on. I truly believe it's breast cancer because actually still have a very high incidence and also increase the incidence every year. And the other thing is about because with the advancement of the medicines, and now these patients have very nice survival. They can even just like past histories and can still live longer and longer than patients have cardiovascular dysfunction. But with the better survival, the other thing is if the patient have a longer lifespan, the other thing is about the happiness about the cardiovascular disease. So we can see there's a curve here, like once the patient have better survivals, but after breast cancer still have to worry about the myocardial dysfunction, which can truly contribute to the eventually the mortality and the morbidities. Okay, so this is the Posner paper published in European Heart Journal. It's about several years ago. Still is valuable because it raised several important drugs that can cause myocardial dysfunction, like doxorubicin, which will still be the first line therapy for patients who have breast cancers, sarcoma, or like lymphoma. And the other thing is about the monoclonal antibodies and also some novel dual tyrosine kinase inhibitor like lapatinib, which we mentioned today. And the other things actually I want to quickly mention is about the hormone therapy, because some patients who have ER and PR positive, they have to be prescribed long-term anti-hormone therapies. And this kind of therapy may also contribute to the ischemia heart disease or like thromboembolic or arterial dysfunctions or hypertension. So I will also quickly mention about the hormone therapy and how it contributes to myocardial dysfunction in breast cancer patients. But first, we had to want to mention that what's the mechanism. So here we can see that if we prescribe the transformer or like trastuzumab, this kind of regimen will directly disrupt the HER2 receptors. And later on, it will have signal transpathways go down to the PI3K and AKT and mTOR. This is very important about the cell proliferation. And also the RAS inhibitor and the like ERK pathways, it can also contribute to myocardial dysfunction and also the endothelial dysfunctions. And so this is the things that we have to pay more attention to. Is like so the off-target effect will cause the endothelial dysfunctions and also the congestive heart failure. Okay. So, but in the past, most of the data is in like Europe or like in the Western countries, but still have an important issue about the cardio-oncology in Asia populations. So I just quickly searched about the researchers and found there's some interesting results that the one paper published in Oman, and it shows that it's about 24% of patients who receive the transdermal and have CTR-CD myocardial dysfunction, even symptomatic or non-symptomatic. But it's quite higher and even higher than the Western countries. In the Western countries, it's only about like 10 to 15%. And like in Korea, there's another cohort populations. It shows that it's about 6.1 to 20% of patients will have CTR-CD within 2 years. And the other paper published in Japan is a single center publications, and it shows that about 19% of patients will have CTR-CD. So this is only like a single center or small cohort, and we just want to know anything about the nationwide cohort. So there's two papers published in Taiwan and use the nationwide cohort, and this one is like from 2006 to 2009, and it shows that the percent of the heart failure or cardiomyopathy after treatment of transdermal is about 4%, which is kind of similar to the Western country. And the other one is the one that we published recently, and it shows this is like a more lasting cohort, and it shows that the 5-year incidence of a major cardiovascular event is about 4%, and the heart failure is about 2.8%. So still have some impact that we have to pay more attention to. And about the lapatinib, and so it's kind of different from the transdermal. It will direct inhibit the ERBB2 receptor here, and it will directly and indirectly cause the dysfunction of the HER2 receptor. So previous studies shows that in the iPSC cells and also animal models, we can find this through suppressing the PI3K and AKT receptor, and also associated with the iKNOS pathways, it can augment the toxicity induced myocardial dysfunction. So if a patient has treated with doxorubicin and also subsequently will have lapatinib therapies, this will possibly cause even worse myocardial dysfunction. And about the incidence, and the previous data we have used the meta-analysis, we can find that even that the incidence is a little bit lower than the transdermal or like the anthracycline, but still have 2.7% of myocardial dysfunction, which means that we still have pay more attention about these patients. And actually something beyond the myocardial dysfunction is that once this patient took these kind of drugs, it will directly go to the cell membrane before this have effect on the transcription, transcription. So actually we have one paper published previously. It shows if the animals, the mice treated with lapatinib, it causes not only myocardial dysfunction, it can also affect the IKS system, which is the potassium channel, and will have QTC prolongation and possibly contribute to fatal arrhythmia. Okay, so once the patient have ER/PR positive, the other things we have to know is about this patient will have long-term anti-hormone therapy, which is very important in breast cancer or like a prostate cancer. So we also have some like nationwide cohort studies about these populations. But there's something very interesting that like in the past from the Western country data, we'll think that if a patient have aromatase inhibitors will cause like ischemia, heart disease, and if the patient have like estrogen receptor like tamoxifen, this patient will have more like a venous thrombosis. But in our cohort, we found that if the patient is old age or advanced cancer stage, actually this patient will have more benefits to be treated with aromatase inhibitors than the estrogen receptor like tamoxifen. So maybe we still have some ethnic difference between the therapies and how it contributes to myocardial dysfunction. The other thing about the CDK4/6 inhibitors, which is like if the patient have postmenopause and have metastatic breast cancers, this will be add-on therapy to aromatase inhibitors. But we already know that these kind of inhibitors maybe will cause the QTC prolongation. So this is another thing maybe contribute to a fatal arrhythmias. Also have some patch pump study shows that it will affect to the IKERG and cause the myocardial dysfunction and also the QT prolongation. So we already have some consensus about if the patient have QT prolongations more than 500 milliseconds. And so if the patient need to prescribe with the CDK4/6 inhibitors, have to under very careful monitor about the QTC. So about the monitoring and the management, I believe that Dr. Hua already mentioned about it. But so use the spatial tracking echocardiography, I think, is a very powerful tool, so we can early detect. And about the biomarkers, I think the biomarker will be have a value to add on. But because that different kind of patient will have different kind of cutoff value about the biomarkers, so I think we need more studies to have an idea about how to apply these kind of biomarkers combined with the images and to have a very nice tool for diagnosis. So this is a kind of quick examples about our patients. Actually, this patient just received the first cycle anthracycline, but we can see significant drop of the strength, and this is more than 50%. While 15% is American Society of Echocardiography guideline recommended cutoff value. So we can see that if the patient only have subclinical myocardial dysfunctions and the drop of GLS for more than 15% will believe to contribute to the subsequent CTRCD or even about heart failure. And then the other thing is about their strength. Their strength is another things that I believe we can have more ideas about how the anthracycline to cause cardiotoxicity. So we combine animal models and the human data, and we found that actually endocardium will be the first site that the cardiac muscle will be affected by anthracycline therapies. And so using their strength, we can do a non-invasive studies and to apply this kind of early detection monitors in our patients. Okay, but how frequent to follow? This is the question I asked Dr. Hua, because actually in the previous guidelines, we had to monitor the echocardiography every 3 cycles or like every 3 months, but there will be a lot. Like one patient, we have to receive about 6 times echocardiography within 2 years. So in our medical centers, we have about 300 to 400 new diagnosed breast cancer. So we have a large volume of echocardiography. So we just quickly to establish, I just quickly jump to this one. Yeah, we could establish the cardio-oncology prospective programs. So we just follow the guideline to do a lot of cardiographies. So till now, it's about 7 years already included patients. There's 500 breast cancer patients, and also we have lymphoma and leukemia. It's about 100 patients. We just want to see is any kind of clue that we can find when to do the echocardiography will have the most beneficial effect, so we can early detect these patients, or what kind of risk factors will contribute to the subsequent heart failure or myocardial dysfunction. So like these programs, we have the audience about how to follow these patients, and we also do the educations to teach these patients and to monitor their blood pressures and their body weight, or to see if any kind of myocardial dysfunction symptoms. Also, we do the blood pressure measurement, also lab quality check, and also about the 6-minute walk distance, and like a CPAT about the myocardial function, and also the spatial checking. So we just quickly raise a flow chart that once this patient have myocardial dysfunctions at each time measurement, we'll quickly go back to the oncologist. And I think the most important thing is that we don't want oncologists to think that we are trying to interrupt their treatment. We just help them to detect the myocardial dysfunction about this patient. And about my patient, if they have subclinical myocardial dysfunction, they don't have any kind of symptoms, they just really have CTRCD, a drop of ejection fraction or myocardial strength, I will try to titrate very low dose ACI, ARB, or beta block to this patient. And fortunately, most of the patients have regained myocardial functions and still can maintain the therapies. But since that most patients, they don't have the high blood pressures, so we only can titrate very low dose. But I still think it's very effective and safe. So this is like the multidisciplines that we include also the breast cancer centers and like cancer centers, and also the cardiologists and doctors rooms, and also the pharmacist, and also the nutrition service, and to want to provide a very nice like a comprehensive treatment and care about these patients. So about this kind of programs, also published in ESC heart failure, that's this truly help and can make the patient have less drop of ejection fraction and reduce their complications like cardiovascular dysfunction or like like hypertension, like arterial event. So this is the thing that we want to do, that if we can do like clinical presentations to see if the patient have myocardial dysfunction symptoms and the strengths, or like do the genetic studies, and to find if we can work on the animal cell models, so we can find possibly candidate drugs which can help these patients and even that can rescue the myocardial dysfunction. So for example, this is one paper we published recently, and we use the cohort and found that these patients have breast cancer, receive anthracycline therapies. If these patients have diabetes, this will make the outcome worse. So we try to do the animal studies and to treat these animals with dapagliflozin, this is SGLT2 inhibitors. And we found it can truly help and reduce the myocardial fibrosis about these animals if they have diabetes. So in cell models, we saw they see that it can reduce the protein expression about apoptosis. So in the future, and it's possibly we can try to do like a clinical studies and to see if we give this patient of SGLT2 inhibitor, which already FDA approved as a half-daily regimen, to see if it can prophylactic or like early treatment will reduce the possibility in the future development of the myocardial dysfunction. Okay, so this is the things that we mentioned in the Taiwan Society of Cardiology. This the guideline about heart failure is one sections about cardio-oncology, and I hopefully I didn't over time. And today I just want to quickly raise some important ideas that CTRCT is not only about the myocardial dysfunction, but can also like the hypertension, so like thrombotic events, and also like even fatal arrhythmia, like QTc prolongations. And today I think the most important thing is still early diagnosis, which can make a difference. We really don't want to see a patient or have severe edema or very worse heart failures that will appear in the cardiac clinic, and we have nothing to do about this patient. So I think early detection is still the key. And the other thing is about the multidisciplinary team care. I think that the collaboration with oncologists, also like breast cancer centers or like hematologists, will be the solution about how to care this kind of patient in the future. And the other things I really want to know is it possible that we can do a very nice registry or collaborations between Asia countries to have our Asia own data, which may be possibly very different from the Western countries. I think this will be very valuable in the future. And this is the logo about our cardio-oncology team. This is the Chime Hospital, and this is the oncology. So I just want to raise quick ideas, and is it possible? And I'd really like to share with all the experts here that we can work together and to provide very nice comprehensive care about these patients. Thank you so much.
Thank you, Professor Chan, for a nice talk. Is there any question? Okay, Dr. Hua, please.
Thank you, Professor Chang, for the very impressive talk. It's so inspiring that you're leading the cardio-oncology research, or your publications are just very on point and very, very impressive. I was very curious and interested with regards to the study of SGLT2 inhibitors. When you mentioned you use animal studies, and with the paper in the title, there was reference to patients. Could you explain a little bit how you actually exposed the patients to the SGLT2 inhibitors? Were these patients all with diabetes, and how did you actually get the tissue samples? Did you have cardiac biopsies to look at the myocardium for the effect of the SGLT2 inhibitors?
Okay, thank you. This is a very nice question. And actually, that's as a cardiologist, I always believe it's very difficult to get the myocardial tissue of the patients, because the things that the myocardial valve still have some kind of risk. So actually, this is the translational studies. We use the dry lab, the cohort about the population data, and to know that they still have some effect about if the breast cancer patients, they have diabetes. Once they've been treated with SGLT2 inhibitor, which they use this one to treat the diabetes, but they still have effect on the myocardial function. So we do the observational in these patients, and all this tissue and the Western blot, like the study, the protein studies, is in the animals and in the cells. So we just want to really get the idea. But I think the most valuable things is we can run like a randomized control studies in the future to see if the patient be prescribed SGLT2 inhibitors or without the SGLT2 inhibitors. And possibly if they treat with anthracyclines, they will have different kind of outcome about myocardial function. I think this is a thing which has more impact in the future. And I would just use the translational study to get the quick ideas about it. But I think the really meaningful things is still about the clinical trial in the future. Especially SGLT2 is a thing that it doesn't have much effect on the blood pressures. Like we use beta blocker, ARBs, but still some patients, if they don't have, if they are normotensive, they are not very tolerable to this kind of drugs. But SGLT2 inhibitor is kind of have only minimal effect on the blood pressures, but still have a lot of benefit on the myocardial function. So I think if we can collaborate in the future, maybe do the clinical trials, which will have very meaningful effect in the future. Thank you.
Thank you so much. I might sneak in another question if there are no other raised hands. You mentioned with regard to the mechanism, and from my readings, even in the clinical studies, we don't exactly know. I mean, we know SGLT2 inhibitors, they cause glycosuria, and we know that leads to sugar lowering effects, but we don't really know the mechanism as to how it causes this cardioprotective effect. We just know that they are beneficial in patients with or without diabetes in improving heart failure related outcomes. So have you in your animal studies, postulated or investigated any kind of basic science laboratory mechanisms as to the specific cardioprotective effects of SGLT2 inhibitors in these animal models that you've studied?
Okay, this is another very good question, because actually we don't have, maybe we only have a little bit, SGLT2 receptor in cardiomyocytes. So how this drug can affect, the myocardial function. So some paper will say that maybe like the other SGLT inhibitors, like the canagliflozin, they have SGLT1, maybe have more effect on the myocardial functions, like cardiomyocytes. But actually, till now, this is like a mystery. That's how these drugs will have effect. Possibly will bypass the kidney, because the kidney have these SGLT2 receptors, and maybe their improvement of like systemic or suppression system inflammation or improve kidney functions can also possibly contribute to the myocardial preservation. But I think till now, we don't have truly about the ideas that how the SGLT2 have an effect directly on the cardiomyocytes. So sorry about that, but I think in the future, very possibly, but till now, we don't have a very exact answer about it. Thank you.
Thank you. Yeah, I suppose, like our ESC, president had said, it's more important that we know it works. We may not know it at the moment how, but that can all happen in tandem. So very inspiring work. Thank you so much.
Thank you.
Thank you, Professor Chan. Because of the time is running out, we go behind the schedule now. So I think we move to the next speaker, Dr. Maria Katrina Prustan from Philippines. She will talk in the topic of cardiovascular toxicity associated with radiation therapy, long-term surveillance and management of carotid coronary and arteriovascular disease. Please.
I think her presentation is already recorded, so could you start the videotape or?
Cannot hear.
I cannot hear. Maybe sound is off. Unfortunately, I can hear nothing.
Okay, is there any problem?
Yes, definitely.
Yeah. Maybe we have to move to another speaker. You think, Dr. Kaneko?
Yes, I agree with
Yeah.
your opinion.
And,
So
yeah.
Can I move to the last speaker?
Yeah.
Okay. So I would like to introduce Dr. Theaprat In Chong Charoen from Thailand. The title of his presentation is Cardiovascular Toxicity associated with immune checkpoint inhibitors. New kit on the rock with new trouble. Could you please start your presentation?
Yes, thank you, Professor Kaneko and Dr. Suphot. So my title is about the immune checkpoint inhibitors. I have no disclosure. So as you know that checkpoint blockade is a promising new therapy in cancer. It's blocked the immune tolerance to the effector T lymphocyte. So therefore potentiating the activity against tumor cells. Immune checkpoint inhibitors are monoclonal antibodies that target the host immune negative regulation receptors such as CTLA4, programmed cell death receptor 1 or PD1, as well as the programmed cell death ligand 1 or PDL1. As you may know that in 2018, Professor Honjo and from Japan and Professor Allison from the United States shared the 2018 Nobel Prize in Physiology of Medicine, discovering the immune system that can be harnessed to attack cancer cells. So this is the mechanisms of the immune checkpoint inhibitors. So on the left panel, you can appreciate that if without immunotherapy, the use of the immune checkpoint by the tumor cells will let the tumor cell to escape from the T cell, from the antigen presenting cell activation. But while using the immune checkpoint inhibitors like CTLA4 antibody, that will let the antigen presenting cell to recognize the cancer cells and then activate the T cell and have the tumor cell elimination, as well as the PD1 and PDL1 ligand, which is the checkpoints that the tumor cell use to escape the T cell lysis. So using the anti-PDL1 and PD1 would eliminate the tumor cells. As in 2018 alone, the FDA granted or update approval of immune checkpoint inhibitor for 11 different indications. The one that we may be familiar with is pembrolizumab, which is quite frequently used in several types of cancers. The downside of immune checkpoint inhibitors are the immune-related adverse events that can be multi-organ. For sure, heart is one of the prominent and most common side effects. Not only the heart that has been affected, there are several organs like brain, nervous systems, the muscle and skeletal muscles, as well as the GI tract and the thyroid gland. So let me present a 58-year-old male with stage 4 non-small cell lung cancer with no prior cardiac history. He received standard chemotherapy by using carboplatin and tremexifed, and followed by anti-PD1 pembrolizumab. He presented with dyspnea about 23 days after the second dose of pembrolizumab. He described his dyspnea as dyspnea exertion without any chest pain and no PND or orthopnea. He also complained of blurry visions and difficulty swallowing. He denies any swelling. So this is his chest X-ray back in July 2021. But at the time that he presented to us is on the July 31st. You can appreciate the increase in the size of the cardiac silhouette here. Actually, the pleural effusion on the right decrease, but you can appreciate the prominence of the perihilar congestion. The initial ECG show significant ST segment depression in V4, V5, and V6. Also, we draw the troponin, and the initial troponin at the time 0 is over than 14, which is the cutoff at our center. And the the follow-up troponin is about 600. So he was diagnosed with non-ST segment elevation, myocardial infarction, and he was treated with aspirin, clopidogrel, and furosemide for the congestion and enoxaparin. The echocardiogram actually doesn't show much. I mean, relatively, the LV ejection fraction is preserved, as well as there is like no wall edema here, and there is some suspected small area of regional wall motion abnormalities. However, looking again on full chamber, it doesn't seem like there is obvious drop of ejection fraction. Seems to be the EF seemed to be preserved. So after the treatment with furosemide, about 40 milligram IV, he diuresed a lot, and actually he felt better, improved the shortness of breath. And then on the second day of the admission, he developed bradycardia. So you can see the heart rate here precipitously dropped. And he also had hypotension with complaint of dizziness. And when we run the new ECGs, and we found that there is some of the ectopy of the ventricular ectopy, like frequent PVCs. And you can appreciate here that the PVF did not conduct well, and there is a heart block here. So this is quite serious. It looks like a complete heart block at the end of this ECG tracing. So what should you do next? I mean, if you face with this patient, so we decided to bring the patient to the cath lab and do the coronary angiogram. And what we found is that he had clean coronary arteries, the right dominant system. So if you look at the at this point, I mean, the patient has no coronary artery disease, but presented with shortness of breath, clinical heart failure, and elevated troponin. But he had a significant history of receiving immune checkpoint inhibitors, which is well known to have cardiotoxicities that include myocarditis, pericarditis, arrhythmias, conduction abnormalities. Not only that, it can also can cause ischemic stroke and the premature coronary artery disease as well. According to the current recommendation, when the patient develops new symptoms related to cardiovascular disease, not only the initial tests like ECG, troponin, BNP, and echocardiogram that include global longitudinal strain, we had to classify the patient into unstable versus stable patients. So in this case, because he had hypertension, heart block, so we decided to bring him to the cath lab and then consider endomyocardial biopsy. On the other hand, if the patient was considered stable, you may use cardiac MRI with parametric mapping, and then consider EMB if there is further clinical deterioration. When the patient was diagnosed with ICI associated with myocarditis, you should discontinue ICI and start methylprednisone about 100 milligram per day, and then follow with the clinical response. So in this case, unfortunately, the day after that, the patient developed dysarthria. And on the physical exam, he also had dysphonia, which like high and low pitch alteration. As well as there is some impair of the ocular motion. He had impaired convergence. So we then get the non-contrast brain CT scan, which showed no abnormalities. The neuro consult localized the lesion as a neuromuscular junction, and they suspect the patient has myasthenia gravis, which may caused by the drug as well. So they proceed with the nerve conduction studies and draw some blood tests for antibody of the acetylcholine. We start treatment the patient with the dexamethasone as a presumptive diagnosis of immune checkpoint inhibitor myocarditis as well as heart block. The endomyocardial biopsy results returned after that about a couple of days, and it showed lymphocytic infiltrates to the myocytes as well as the myocyte damage. and it's stain positive for PD-1 receptor. We also had the immunohistochemistry studies looking at the different CDs staining, and the most obvious and most striking is about the staining positive focal expression of the immune cells with stain positive for PD-L1. So the final diagnosis is lymphocytic myocarditis, which is likely to be related to immune checkpoint inhibitors. He also had elevated the creatine kinase, which is a muscle enzyme, and we diagnosed him with the myositis as well. We run the panel of the viral profile as well as mycoplasma and COVID-19 in the myocardium, and we found no viral infection in the myocardium. And all the autoimmune panel like ANA, anti-MPO, and PR3 were negative. We also confirmed the myocardial involvement with cardiac MRI, which show increased T2 mapping signal consistent with myocardial edema without clear delay contrast enhancement. And all these features are consistent with myocarditis. So according to the treatment, we divided the severity of the immune checkpoint inhibitor myocarditis into 4 grades. The grade 1 is mildly abnormal screening test, no symptoms. Grade 2 is abnormal screening test with mild symptoms. Grade 3 is severe with moderately abnormal screening tests like arrhythmias and significant abnormal echocardiogram findings and symptoms with mild activity. And grade 4 life-threatening. There is like hemodynamic instability or elevation of cardiac biomarkers. So in any grade, you should withhold the immune checkpoint inhibitors, and in grade 2 or 3, you should give the oral prednisone, while in the grade 4, we use the IV methylprednisolone, and then continue the treatment for about 3 to 5 days. And then you can step down to oral prednisone after that. If there is no improvement within 24 hours, consider ATG or infliximab or mycophenolate mofetil. And you should have advanced heart failure management, including hemodynamic support with ventricular assist device as indicated. So in this case, when we got the final definite diagnosis from the endomyocardial biopsy, we start the patient on pulse methylprednisolone. The neurology consult gave him mestinon to treat the ocular myasthenia gravis. We continue the methylprednisolone for about 3 days, and then you can appreciate his heart rate went up, and then the symptoms of high blood and hypotension improved. So we stepped down the IV prednisone to oral prednisone about 60 milligrams per day. And this is his ECG before discharge. He returned back to normal sinus rhythm, and the telemetry show no evidence of heart block. The X-ray improved, and clinical was well. So this is a case that show you acute de novo heart failure with the final diagnosis of acute myocarditis suspected from immune checkpoint inhibitor from pembrolizumab. And he also had ocular MG with bulbar involvement and myositis. So we had to discontinue pembrolizumab after this. In summary, ladies and gentlemen, cardiovascular toxicity associated with immune checkpoint inhibitors can present in several parts of our cardiac system, including but not limited to arrhythmias, myocarditis, vasculitis, pericardial disease, also Takotsubo-like syndrome. Myocarditis is the most common cardiovascular immune-related adverse events related to immune checkpoint inhibitors that occur in up to 45%. And about 1% of this patient with occurs in only 1%. Those who were treated with immune checkpoint inhibitors. The median onset from the literature is about 34 days. It's actually quite similar to our case. It's more common and severe with the combination checkpoint blockade and more with anti-PD-1 than the anti-CTLA4. The management, first you need to withhold or discontinue the ICI, and for severe reaction, treat with steroid and then taper. If it's non-response, consider ATG or other alternatives. In the latest 2021 ESC guidelines, it was recommended that you check troponin weekly in the first 4 to 6 weeks when there is a treatment of immune checkpoint inhibitor. I'm not sure whether it's practical in our practice, but that is a recommendation because it usually occurs during that 4 to 6 weeks. And then if there is only asymptomatic troponinemia, you do work up and then follow the patient. But if there is a myocarditis, you should classify whether the patient is stable or unstable. If it's stable, you admit to the floor and then do the workup and start the treatment. If it's unstable, consider not only treatment with the same treatment, but consider admit to the CCU and do the heart failure and referral to the Advanced Heart Failure Center for consultation. And with that, thank you very much for your attention.
Thank you, Dr. Srimachota. Very, very nice case. Yeah. Is there any question from the audience?
Yes, Professor Shang.
Very nice presentation and congratulations about the fully recover about these patients, because I think it's really not easy, because we had look back to the patient that we have IO therapies, immune checkpoint inhibitors in our hospitals. Actually, we found that it's possible patient that we have myocarditis, but none of these has been successfully rescued. So I think the pump therapy with steroid and also immunosuppression is very important. But my question is, think is it possible any kind of clues we can know this kind of patient will have like a severe myocarditis before the treatment, or if the patient have early extracardiac symptoms, like if they have different kind of IRAEs, and any kind of clues that we can possibly know that this kind of severe symptoms will possibly happen in these patients. Thank you.
So I think it is quite difficult because sometimes the symptoms are subtle. And I think that's why the current recommendation try to encourage screening with biomarkers as possibly the early clues, as well as the strain imaging by echo that probably can detect early stage of the disease. So in the severe form, usually there are multiple organ involvement. As in my case, it can have neural and myocyte damage as well. That has been elucidated very well in the literature that in case we have multiple organ involvement, usually the cardiac involvement is also quite severe as well. The other clue is like when you have significant arrhythmia, either tachyarrhythmia or bradyarrhythmia, especially advanced degree AV block. That is the clues that you probably should undergo like invasive therapy. And I would recommend not to wait for the endomyocardial biopsy results, but try to treat the patient in case that you are suspected. And then you can change, like you can escalate the care, or you can withdraw the treatment after you get the test result come back. Yeah.
Thank you.
Thank you. Is there any more question? If don't have any question now, we back to the last speaker, Dr. Maria Catherine Tan from Philippines. Please start the video. Thank you. I still cannot hear anything. Try again.
Let me try it again.
Yeah. Still problem.
I'm sorry, I cannot get the audio off.
Maybe you, I'm not sure how to connect the problem.
This journal provided a practical approach to diagnosis and management in radiation-associated cardiac diseases or radiation-induced heart disease, because we know that advances in mediastinal radiation in the past 50 years has contributed to better survival in patients with thoracic and breast malignancy. But we know since in the 1920s, the norm was then to minimize minimizing cardiovascular radiation was actually not the norm during that time. And during this time, high dose
we have audio, but no, no picture to see.
among survivors of Hodgkin's lymphoma.
Oh, that's the problem.
These would then, you can see, manifesting decades after treatment that probably results from either diffuse interstitial fibrosis and collagen deposition. So now we do have contemporary measures to minimize radiation. And based on the study,
I'm sorry, I cannot get it to properly to run. Sorry.
Yeah.
So Professor Lin,
Yeah,
maybe,
I see. Maybe we can just move on to closing remarks.
yeah,
We'll try
Yeah.
to fix it and maybe edit it and put in the final file. Okay. Thank you.
Yeah.
Anyway,
Yeah.
yeah.
yeah. Sorry, so sorry.
Okay,
Yeah.
no problem. Yeah.
Okay, yeah. So I think we come to the end of the session. Yeah. I hope you will enjoy the webinar meeting. Before I close this session, I would like to thank all the speakers, Professor Kaneko, and of course, Professor Julian Lee Lins, Program Director from National Taiwan University Hospital, the representative from the APSC. I hope everybody enjoyed this meeting. Bye-bye.
Bye.
Thank you.
Bye.
Thank you. Thank you all.
Thank you.
Thank you. Okay. Thank you.